Right, hello, welcome. My name's Lionel Nagle. I'm a GP. I'm a GP at the Pall Mall Surgery. I've been there for 27 years. You can tell I'm looking old and rusty. And I've been a programme director on the Southend GP training scheme for 21 years. So I've been around a very long time, and I should be put to sleep at some point. I'll probably drive you to sleep as well. And those of you on the training scheme know I fall asleep very, very easily. So I'll try not to fall asleep doing this. Right. Next slide. You've passed. You're a doctor. Yay! Not only are you a doctor, you're a general practitioner, and you are a member of a Royal College, a very, very important Royal College. In fact, the most important Royal College in the country. It's the biggest medical Royal College of the lot. And we are very, very important Royal College. And you are members of it for passing all those wretched exams and paying thousands and thousands of pounds for CSAs and AKTs and goodness knows what. So well done, congratulations. Becoming a GP is no longer, well, if you can't do anything else, go and be a GP. It is now, go and be a GP, and if you can't do that, do something else. It is actually a very difficult thing to do. Well done, congratulations. So, you're a GP. Next slide. Right, bias warning. Apart from the fact that I'm enthusiastic about general practice, I'm very enthusiastic about Southend-on-Sea, because I'm a local boy. You can possibly tell there's a bit of an Essex twang in my voice. I went to local schools. I was brought up not even a mile away from where I practice. I see the school. I went to my junior school, or when I'm going to work, I see my senior school because it's near the hospital. So you can see I'm a local lad made good, and I'm very proud of my town. And you're going to find that I'm going to promote practice in Essex and Southend as a very good thing to do. Recognise that? Yeah. Okay, we're coming back to that in a minute. Next one. So, what next? You've trained, you've done 5 years at medical school, you've done foundation jobs, you perhaps have qualified in another country, worked in their medical system, come over to this medical system, done loads of other jobs, then got onto a training scheme for 3 years, taken exams, and then you decide to do nothing, retrain, leave medicine. Well, a lot of people do leave medicine, fool them, but nevertheless they leave medicine. Or the best thing you can do is go and get into general practice and change things and make things better. All right, so this is what it's all about. Now, you've probably heard of a new contract. It's not brilliant, but basically the government at long last has understood that general practice needs more help and is the key to innovating and improving medical care in our country. So we are really at the cutting edge of making things better. Hospitals can't, they make a mess of things. You know, they overspend, they're bureaucratic, they're hierarchical. General practices are smaller, they're more proactive, they're more able to change. And you're part of that generation of doctors that's going to do that. Can I have the next slide, please? These are areas that are all going to be improved. There is going to be improvement in funding. It won't be going into individual practices, but it will be going into groups of practices working together in localities. Indemnity has been simplified in the sense that the indemnity will be paid for by the government, the basic indemnity. There will be need for the MDU and the MPS, etc., but your basic indemnity will be paid for. So you have, all of that has gone, that worry about it. There'll be these networks of practices working together. There will be a lot more technology, Skyping, all sorts of things like that. And the things about QOF, which you may have heard about, will change. So, next slide. What does this all mean? Well, we are going to be the forefront of this change. You are, rather. I'll be probably pushing up daisies before you know it, but you won't, and you're the future. So we're no longer waiting for people to die to become the senior partner or whatever. You will actually be... Jose's already poisoning my tea. You are actually the start. So now you've qualified, you're a GP, you are now at the cutting edge of medicine and change in this country. What are you going to do? Well, these are your options, and you probably know these options already. Locum posts, salaried posts, partnership, innovative posts, GP with special interest, and portfolio careers, and the retainer scheme. You don't need to worry about the retainer scheme, that's for old people like me. GPs with special interests, well, that could be what I do, because I'm a programme director and I'm a GP. So I've already got a small portfolio, not as big as Rachel's. It's a tiny one. In fact, it's an envelope, really. But I've got an envelope career with two things I do rather than one, and I would encourage all of you to at least have an envelope career, because otherwise you'll go bonkers. Okay, so that's next slide. Right, so positives and disadvantages of being a locum. Now, some people say, oh, well, when I qualify Lionel, I just do a bit of locuming. Okay, that's fine, that's good. Certainly, being a locum gives you freedom. You can work in a practice you don't like, you can never go back there again. You can try things out. You're self-employed, you can claim everything against tax and all of that sort of stuff. You claim your expenses. You get wider experience. You can work in practices you never thought, well, I wonder what working in a small practice in Shoebury-Ness or Canvey Island is like. I never had the experience. Let's go and try it out. You might like it. So it's a good thing to do. No ties. The demand is high. If you're a locum, you could do your job twice. You know, there's so much need for locums. Okay, you get a lot of money for being a locum. It's a lot of money. However, it is not stable income. If the work dries up, you are self-employed, which means you will have to do all sorts of recording how much you spend, how much you earn, getting your tax your tax returns correct, making sure you claim for expenses. Expenses are a benefit and they're a curse because you have to write down everything you spend and you mustn't claim for the wrong things. More importantly than that, you're not part of a team. You're a locum, you come along, you go away. Now, those of you who work at Pall Mall will know we have locums. And sometimes the locums will have come and gone all week and we've not actually seen them because they come, they do their job and go away again. Perhaps that's what they want. But if you want the concept of being in a team, part of being a group of doctors working together, a community of practice, the medical education jargon we use, then actually not necessarily going to get that. Continuity of care can really go down the pan if you do 3 days one place, 7 the next, and you're all over the place. You're never going to see the same patient again, follow them through. And some patients, wrongly, are quite disrespectful of locums. They go and see the locum, and then they come and see me the next day. Oh, I saw the locum. What does she know? She says I've got an ingrown toenail. Yeah, you've got an ingrown toenail. Goodbye. Next one, please. Right. This is the next job that people talk about. It's being called a salaried. We're a bit pompous at Pall Mall. We call them associates because you are actually, we like to think you're more than just that. So when you're a salaried doctor, you get stable income. You get pay as you earn, so your tax is paid for. You get sick pay, annual leave, you're part of a team. There should be some professional development there. You are involved with continuity of care, you do see the same patients. And it's not like marriage, where it's difficult to get out of. It's a bit like sort of loosely living together. You can sort of give up and move on if you want to. It's not that easy, you have to give notice, but being in one practice and thinking it's not right for me isn't the end of the world. You can get out and it doesn't cause a lot of problems. You do have to give notice. There is a risk that some practices, particularly if they haven't had salaried doctors before, might exploit them, and you do have to look at your contract to make sure the contract is fair. You might not get management experience, so you might not learn how the practice manages. Some people might feel they're almost like a staff grade status. The problem with staff grades in hospital, sorry, can you hear me better now? Staff grades in hospital is that they often feel neglected or they feel just a bit dismissed. I don't think salaried doctors in general practice do, but there is always that risk and you must always be sort of aware of that. So then we look at out of hours work. You've all done your out of hours, all 108 of it when you've got through. You get loads of money for doing it. You basically see patients, you're always in demand, you can do it at the end of the day or whatever, antisocial hours, patients don't respect you, lack of continuity of care, and you work for a big organisation. We do need people to work out of hours, it's very important, there has to be an out of hours GP service, but it is hard work and it is a style of working, and actually it's probably something you should portfolio in bits. So you shouldn't necessarily have an envelope career of out of hours. You should have a big offer. And just like Rachel does, she does a bit of out of hours, she does a bit of this and that keeps her sane and it's useful. But it is a useful thing. And then we've got partnership. And this is the thing that eludes people worry about. And I know we've got a tax expert going to talk about, a legal expert rather, going to talk about partnerships and the legalities of it. So I won't interfere with that. But being a partner gives you control. Being in a partnership, unlike being a consultant in hospital, means you can change the direction of the practice. You can introduce change. You can make things different. So one of the things that has always excited me about where I work is that we can be innovative. And we don't have to wait for the CCG or anyone else to tell us what to do. We can do it. And that is great. You know, you have the freedom, you work out the business plan, the money is there, you do it. And that is a very, very important thing that you can do. You possibly get more income. These days, the gap between salaried and partnership income is much less. You do earn it if you're a partner. You take risk. You do have to put more hours in, but you do earn more. So it's a good thing to do. There is continuity of care. You very much are part of the community. You're around for a long time. People get to know you. People get to know you, and they say, "Oh yes, you did the postnatal on my last child. Oh yes, you looked after me when I was a little girl." That sort of thing. So I've got to the stage now. I'm doing postnatals on people who I did the postnatal baby check on 22, 24 years ago. So you're part of that community, and that's nice. It makes you feel that you are worthwhile. It is a true partnership. We are a partnership. We share the money. We share the workload. We share the things. One person doesn't get more money because they're older or they're uglier or prettier or whatever. We all get the same according to the number of hours we work. And that's good. I did say responsibility is a good thing. It's also sometimes can be a negative. You are responsible when there's something hits the proverbial fan, you're responsible. So if someone doesn't turn up and their patient's to be seen, it's your job as a partner. You can't say, "Oh, I've seen enough today." You're a partner. It's your business. You do it. You have to get cope with the tax system. It's taken me 27 years and a lot of discussion with my accountant to really understand the tax system, but I'm probably one of the few people in my practice who understands it. It is a long-term commitment. It's really important, but it is a good thing, a long-term commitment. Long-term commitments are what keep societies, communities, etc. together, so it's a good thing. It is also a very different system to what the rest of the NHS has. In the rest of the NHS, you work in hospital, you're paid by the trust. In general practice, you are self-employed. You've got a contract with NHS England, yet you have the advantages of the pension scheme, etc., which is very much your advantage. You're very lucky like that. Next one, innovative posts. There's clinical commissioning schemes and fellowship scheme. I'm not going to talk about that now because I haven't got enough time, but there are innovative posts out there. Rachel in particular is very keen on these. We're introducing them where you have in effect an ST4 post where you do a couple of days in general practice, a couple of days either in community medicine, public health, hospital, and the fifth day you do studying towards a postgraduate qualification in that area. So it helps you to become that GP with special interest. These are new posts. They're posts that you have to be applying for, possibly too late for some of you. It has to be applying for them towards the end of ST3. They are exciting. They are going to become more and more important as the future goes on. But there's something you might wish to think about. It's not a cop-out because you have to work quite hard at them and you have to do some academic work, but it's a good thing to do. If you could just skip the next two slides. Right, we've done the portfolio career with Rachel. Just want to say that it does fit. Most people do end up with a portfolio career, and it is satisfying. And remember the educator role as well, that being a GP trainer is why you're here. If it wasn't a GP trainer, you wouldn't be sitting here. So it's important that you consider later on that you too become a GP trainer. It is slightly protracted event these days, but it is worth doing. It involves getting a postgraduate certificate in medical education. It requires your training practice to be up to scratch, etc. This is a very important role, very useful role. It's a bit like teaching in any area. If it wasn't for teachers, none of you would even be here. If it wasn't for medical educators, you wouldn't be here. So it's a very important role. Next one. Okay, so your GP progression can go from locum salaried partner, that's the traditional way. It can go from salaried locum to salaried. Next slide. It can go from salaried to portfolio. It can go salaried partner. It could go any way you like. So there isn't any more obvious progression. But usually when people do become partners, it is a pretty substantive position. Next question. Next slide. What general practice isn't? Next slide. It's not a second choice career. It's not easy medicine. Far from it. It's difficult, complex medicine that requires your skills as a clinician. Actual physical examination skills, examining, listening, history taking. You know, it's very good to be an orthopaedic surgeon, it's very clever, but you look at some MRI scans, follow some protocols, and you get your drill out. What we're doing is seeing people right from the start with none of that and working out what's going on with them. It's a very, very, very difficult, important specialism, and actually it's a specialism that treats most people. It's not a license to print money. The idea is that GPs, easy work, golf club in the afternoon, drive a Bentley. Sorry. You will have a good career, you will have a lovely standard of living compared to most people in this country. You'll be very well off, and you deserve to be because you work hard, but you're not going to be mega rich. If you want to do that, go into plastic surgery in Harley Street or something like that. Okay, next one. General practice is flexible. We're talking more and more about flexibility. I was looking at the end on those things down the bottom, and I was impressed to see that people were more interested in flexibility than money. That's quite good. I'll tell all the people in my staff practice that. It is multi-professional. Being in a general practice isn't just the doctor, the receptionist, and perhaps the nurse anymore. It's none of that at all. There are myriads of people who work in our practice. Dementia care nurses in our practice, physios, paramedics, emergency care practitioners, all pharmacists, all sorts of people work within the primary care setting with you, and you're to deliver that goods. And you're key to that. You're very much the pivot of that. We are pushing towards longer appointments, the 15-minute appointments you hear about. We're going to see the complicated cases. We shouldn't be seeing ingrown toenails, quite frankly. You're too highly qualified for that. You should be dealing with weight loss, chronic change in bowel habits, all those things that need your skills. And it is suitable for people who are patient-centred doctors. Right, not doctor-centred, right. Is this Essex fishing village Britain's happiest place? I wonder where that could be. Now, I don't read the Daily Telegraph. I don't want any of you going away thinking that. I was told this by a friend. Well, they're still a friend, even though I read the Daily Telegraph. Right, the next one. Where's that? Leigh-on-Sea. And do you know what? Next slide. You can work in Britain's happiest place if you want to.